in a cisgendered female patient. So is most prevalent in women who are African American?
No.
No. So for the person who said no, I can't. Oh, actually, Michael. So what is luminal A breast cancer?
Which Michael?
Oh, Michael Real. Oops, you're on mute. Sorry.
You just said luminal A virus cancer?
So yeah, what type of breast cancer is luminal A? So we just talked a lot about like what receptors are involved.
So the luminal A, that one has the HER positive?
So luminal A is HER2 negative.
Oh, HER2 negative, okay.
Mm-hmm, yep, and then can anyone else, Knock, you want to help him out with what kind of hormone receptor positivity or negativity will we see with luminal A?
This will be hormone positive.
Perfect. Okay. So based on that, so Michael, back to you. So based on that, do we think that luminal A breast cancer is most prevalent in women who are African American? No, right? Which kind of breast cancer is?
Can't recall.
Okay. Can someone else help him out?
Triple negative.
That's right. Thank you. Okay. So let's go through the rest of this question. All right. Can a luminal A breast cancer be treated with a drug that blocks estrogen progesterone receptor?
Yes.
Yes.
Yes, exactly. So that is the right answer. Can it be treated with an anti-HER2 therapy?
No.
No, because it's always HER2 negative, right? My whippet came back to say hi. Sorry. And does it have a high presence of Ki-67?
No.
Nope. What would be its kind of badass sister that would have higher levels of Ki-67?
Luminal B.
That's right. Okay. Awesome. So I think we seem to be much more comfortable with this now, right? Excellent. And of course, now she's whining in the background. It's great. All right. Which of the following decreases your risk of breast cancer? Select all that apply. Does physical activity decrease your risk?
Yes.
Yes. Being active is good, even when we're quarantined, right? A lot of steps in the house. Okay. What about pregnancy if you're getting pregnant below the age of 30?
Yes.
Apparently, all bad things happen to the body when you turn 30, unfortunately, especially as it relates to breast cancer. For me, I got psoriasis at 30. I was fine. And then I was like, what kind of dark magic is this? All right. Early menstruation and late menopause. Is that good for prevention of breast cancer or bad?
Bad.
It's bad. Why is it bad?
More exposure to the hormones.
Yes, exactly. And it also means that sometimes those patients are much harder to treat. They may be refractory even to some of the adjuvant endocrine therapies. So one of the things that we do when we evaluate a woman who's being diagnosed with breast cancer is get a really good history, detailed history. When was your first period? Are you in menopause? What age did your mom go into menopause? Or biological parents. That information is really important. And sometimes it will also give us a sense of risk for a patient in terms of progression or recurrence. And we'll talk a little bit about that in a minute. Routine screening mammograms should continue to at least 80 years of age for women of average risk. It's false, right? So 74 is the cutoff. After that, if a woman has a life expectancy of more than 10 years, then it would be reasonable to continue it. It's also up to a woman if she wants to. So perfect example. My mom is a breast cancer survivor. She was diagnosed in 1989. She was 49 years old. And she had luminal A breast cancer. Well, we now know that it was luminal A. We didn't really have that information back then. But she started on tamoxifen. She was on tamoxifen for about 10 years. So for her, when she turned 74, 75, her oncologist said, because you had breast cancer and she had a mastectomy, the oncologist asked her, do you want to continue, having mammograms? And my mom and I talked a lot about it. And she was like, I'm probably going to live to 100. And that's true. But I don't feel like, putting myself through the stress of doing this every couple of years. So she decided not to. But it really is an individual choice for a woman. I'm going to kick my whippet out. Sorry, just 1 second. Okay, Eloise, come on. Honey, I'm locking Eloise out. Eloise keeps coming up here. Drive me nuts. Sorry about that. Apparently having a dog is like having a child. Okay. So we're good on that, right? Okay. All right, so PD is a 52-year-old transgender male who was diagnosed with stage 2 luminal B breast cancer while preparing for top surgery, okay? And that's when a person who is transgender decides to have their breasts removed, and often it'll mean doing like what's called a masculinization of the chest. The reason why I keep throwing these terms in is because you will encounter them, and I want to make sure that you're comfortable with these terms because, again, I don't know how much of it you've gotten through your education. So when you get onto your rotations, I don't want you to have the deer in the headlights look when your preceptor says, oh, my patient who's transgender. So I just want to make sure that you guys are comfortable with that. Okay. So the nurse practitioner seeing the patient would like to know if an Oncotype DX test is required. So choose a correct response below. Yes, because luminal B breast cancers require HER2 positive blockade.
No.
Nope. So first of all, luminal B, it could be either way. They could have HER2 positive or HER2 negative. That's not pertinent to an Oncotype DX. Yes, because his type of breast cancer is hormone receptor positive.
Yes.
Mm-hmm. No, because luminal B cancers are more aggressive. Doesn't matter. Or no, because the test is not useful in early stage breast cancer. Also not true. So tell me, let's see. Sorry, I'm going through the list here. I can't see everybody's face. Thomas, tell me a little bit about what an Oncotype DX test is. So when do we use it?
Not sure. Let's see.
Okay. Do you want to phone a friend? Someone else want to help?
Anyone on my team?
Come on, don't make me do the awkward Jeopardy song. Somebody please help him out. So anyone who knows the answer at this point.
Isn't it like how likely it's to reoccur again?
Correct. So that is absolutely true. But do we use this in all kinds of breast cancer?
No, early stages, if I'm not.
So early stage is true, but then there's another requirement. And what is that other requirement?
If they're hormone positive.
Exactly. So why do we use the Oncotype DX besides the recurrence risk? What does that do in terms of helping us decide treatment?
To know if they can benefit from chemotherapy.
Exactly. So when I have a woman who has a very early stage breast cancer, I need that number to determine in some cases when someone is kind of borderline from a clinical staging perspective or pathology perspective. This really, really helps us decide if we have to expose someone to chemotherapy. If I can just give somebody hormone therapy and send them on their way, that's a much better experience for a patient than having to expose them to something as toxic as chemotherapy. So we use this as a clinical decision-making tool to help us. Now, it's not perfect, right? Because if you get like an intermediate or indeterminate number, then sometimes it's a little bit harder. And so you really have to kind of walk through with the patient what what we think their percentage risk might be of having a recurrence. Now, if they have a familial, like a strong familial history of breast cancer, especially occurring at a younger age, then sometimes, if that score is indeterminate, it's an easier decision to make. We just say, yeah, let's go ahead and use chemo. Cool. So are we good on that?
Dr. Leva?
Right.
Yeah. I have a quick question. So basically, like when you're analyzing the test, like is it associated with numbers then? Like is that how you read it? Okay.
Yeah, so 0 to 100. So we basically just, the lower your score, the better it is. So, and it's just about risk of recurrence. Yeah. And I'm not going to have you guys memorize that. I just want you to know that that's one of the tools that we use to decide if a woman would benefit from chemotherapy. It's, do we need to use it as an insurance policy essentially, or can we save the healthcare system and the patient from this kind of intervention? Because remember, all of these treatments are very expensive. So even if a lot of the chemos that we're using are old and they've been around forever, which is actually pretty common for breast cancer, we're still having to insert a port because most of these drugs cannot be given peripherally. So that's a cost, right? And there's also a risk associated with that. And then you're using up chair time, and insurance companies have to cover additional things that patients need, like if they end up getting febrile neutropenia, that's expensive, right? Especially if they end up having to go to the emergency room. If they end up having nausea and vomiting or some other kind of adverse event, that is a cost to the patient and to the system. So, I wish we had these tools for a lot of other kinds of cancer, especially prostate cancer. We really, really, really need this in prostate cancer because I think we're doing a lot of harm because we don't have a good way of making decisions about whether or not we should expose patients.
Is there a cutoff number for the oncologic disease test? It just says low numbers. So the lower the number is, okay.
I'm not going to have you guys, because the thing is that it depends on the agency who's running, or the lab who's running the test. And it also depends on the specific protocols of the institution. So you don't have to worry about that. I don't need you to know the reference range. I just want you to understand that lower, less risk, higher, more likely going to need to treat.
I guess more importantly, not necessarily a specific number, but are we talking about like 10's considered low or 70 considered low? Like
70 is not considered low.
Well, no, I know that, but that's why, because there was that range of 30 to 90 on one of these things. So I just, if
exactly
come up, so we have a general idea in our
head. So usually, yep. So I would say normally, trying to think of the last institution, I think our oncologist had, like, if it was less than 21 or something like that, then we didn't necessarily encourage a woman to have chemo. But it just, again, it varies a little bit. So that's why I didn't want you guys to get stuck with the numbers. I just want you to know it exists. We use it as a tool, and we only use it for early stage breast cancer for patients who have hormone receptor positive. Why wouldn't we use it in a late stage or metastatic? I see shrugging like, what?
Chemotherapy, so hopefully they're already being treated.
Right, exactly. I mean, you're not worried about recurrence. Unfortunately, they have the worst case scenario, right? They have advanced or metastatic breast cancer. Exactly. All right, cool.
Dr. Leva?
Yeah.
Does lymph node involvement have anything to do with the Oncotype DX test?
Well, that would be more related to stage. So if you're a higher stage, you're likely to get chemo regardless. If you are very low stage, like stage 1 or maybe stage 2A, and you're kind of borderline, that's really where that Oncotype DX test comes into play. Because we really do treat women now earlier and earlier with chemo. We didn't used to. So we used to really kind of focus more on like stage 2C and above, but then we found that patients were having poor outcomes because they were having a recurrence. So, all right. So some of the treatment modalities for a woman with stage 4 breast cancer may include adjuvant endocrine agents, Xgeva, and radiation therapy. True or false?
True.
True. That's right. What is Xgeva? That's right. What do we use it for? Well, we do, yeah. So we use it for cancer that is either metastasized to the bone, and we're worried about what's called a pathologic fracture, or we use it to prevent metastatic disease from going into the bone and causing a pathologic fracture.
So rheumatoid arthritis?
What's that?
Is it involved in rheumatoid arthritis as well? Was that not?
Prolia. No, I mean, we do use Prolia for osteoporosis and treatment-related osteoporosis, but Xgeva is the drug that's used pretty much primarily, the indication is for cancer patients. So either prevention of bony metastasis or treatment of bony metastasis to prevent pathologic fracture, or we can also use it to lower calcium. So it's not a super fast-acting drug, but it's really good for lowering calcium when someone's hypercalcemic. Cool.
Zometa and Xgeva are used for like hypercalcemia malignancy, right?
Mm-hmm. Yeah, we prefer to use Zometa because it's much faster acting, and frankly, it's a lot less expensive. And also, it's a little bit, because it's not a sub-Q injection, the kinetics of Zometa are a little bit easier to anticipate. The one benefit, though, of Xgeva over Zometa is that Xgeva doesn't exactly have a hard contraindicated serum creatinine cutoff. So we don't dose adjust it for that. And sometimes that comes in handy because if their calcium levels are really high, it can cause acute kidney injury. So sometimes we have to keep that in mind. Cool. All right. You guys ready to move on to the exam? You stoked? Yeah, it was so much fun to write it. Yeah, no, not really. Exams are not fun to write. They're probably even less fun to take, but all right, I see a question here. Ooh, that's okay, no problem. And for those of you who can't have your video on, it's okay. It's just as much as possible. I like to be able to see your faces so I know you're alive and well and participating. All right. So I'm not going to share my screen, obviously, although I almost just did, which would have been unfortunate for me more than for you. Oops. All right. So I'm also going to record this session for your classmates. Well, for all of you, but especially for those who might not have been able to join us today. All right, let me see if I can record. Okay. I really hope this is going to work. I'm actually going to open up a separate recording app just to make sure. Okay. I'll just use my phone. All right. Okay. So the test is 30 questions long, and it's mostly broken out by like 5 questions per topic day. There are a couple of topics that maybe got like I stole from one day. You know, it just depended on the mechanics of the exam and making sure that I was able to ask you guys the right kinds of questions. So a couple of things, you definitely need to understand the hallmarks of cancer, okay? And make sure that you understand, some of the ways in which cancer cells behave differently than normal cells. And again, I'm going to keep it fairly high level, but I definitely want you to just sort of be able to understand a few of the biological principles that we talked about, including the definition of oncogenes. All right. Also, for staging, I just want you to be able to identify what grade something is. So, we talked about like, well differentiated to undifferentiated or poorly differentiated, et cetera. So that's important just so that you have the knowledge of being able to identify what a pathology report means. For staging, I want you to know the difference between an early stage versus an advanced stage versus metastatic. So, for example, if a woman has breast cancer, right? She has a primary tumor on her breast, and let's say she develops a pleural effusion. And when we do a lung tap, we find that she has malignant cells in her pleura. So what stage would you assign that? Just with that information alone.
Is it metastatic? Stage 4?
Exactly. So any kind of cancer that is outside of where the primary tumor started would be considered metastatic. Okay? So it's not so important that you memorize like necessarily all the sizing of everything, but it is important that you have a vague awareness of, what would constitute something that's early stage, something that's advanced, and something that's metastatic.
Dr. Leva, real quick, you said that was early breast cancer to pleural effusion, right?
So, it would only be early stage and then becoming pleural effusion if, let's say, she was diagnosed with both of the same, or if she was diagnosed with breast cancer, primary tumor, and then like a year later she had, the malignant pleural effusion, then she would have probably gone from stage 2 or whatever to stage 4. If she was diagnosed with both at the same time, which is also common, then that would be just an automatic stage 4 diagnosis.
Okay, thank you.
Mm-hmm. We tend to go up in stage always, not ever down. I wish it were that way. But usually staging gets worse. Okay. Yeah.
What's like the best way to figure out if it's advanced in a case?
So I'd have to give you a lot of clues, right? I'd have to give you like big size T. So T3 or T4 and a bunch of nodes, right? So I'm not worried so much about the numbers. I just want you to have the concept of like what an early stage, what an advanced, and what a metastatic is. Metastatic are usually pretty obvious, right? You've got something happening outside of where a primary tumor is, either at the same time or later on.
Okay, perfect. Thank you.
Yeah, no problem. And I try, especially for stuff like this, I mean, this is conceptual. I just want you to be able to understand it. I'm not going to be mean and be like, give me the, T2 and, I'm not going to ask you to do the TNM. Okay. And then for screening, I just want you to be able to know which cancers we screen for. When we start getting into the individual cancers, I'll start asking more questions like breast cancer. We'll talk more about mammograms and stuff like that. But I just want you to have an awareness of the kinds of things that we screen for and like what's kind of age appropriate for somebody if I give you a case. Okay. Incidentally, which cancers do we screen for off the top of your head?
Prostate.
Yeah.
So prostate,
breast cancer,
breast cancer,
lung,
colorectal cancer,
skin,
cervical.
Perfect. Awesome. For lung cancer, do we screen everyone?
No.
Yes.
Right. So we screen people based on their age and their PAC per day history. Perfect. We missed one though. So we said cervical, prostate, lung, colon, breast. What else? There is another one on there. We just
skin.
Yes, we do actually screen for skin cancer. That's a great one. There's another one. There's another female organ that we kind of like half-assed screen.
Ovarian?
We don't actually screen for ovarian specifically, but you're not fully wrong, because we do also, in people who have a risk of the BRCA mutation, we do check to see if they're higher risk. We just don't have a good screening mechanism for being able to see if someone has ovarian cancer. That's all right. I'm going to throw it back to you guys and you can look it up. So we named a bunch, but there was one specifically that we did not name.
Is it endometrial?
It is. Yeah. That's awesome. Good job. All right. So let's see. We talked about hallmarks of cancer. Also important to know the steps in the process of a a normal cell transforming into a malignant cell. Again, pretty straightforward, high-level questions based on what you've been exposed to before. All right, we talked about screening. Make sure you take a good look at the cell kill hypothesis and understand that. Again, it's pretty easy. We talked about it in terms of in the lecture in terms of how we approach treating cancer when it comes to how we do cycles, how we schedule cycles, how we dose, things like that. So make sure you understand that. Okay, so you definitely need to know the Calvert formula. And you guys already know how to calculate creatinine clearance, so I'm not worried about that. But the Calvert formula is important. Anybody want to rattle off the Calvert formula to impress your classmates and me? Admittedly, I'm easily impressed, so. No takers. All right. Well, you'll need to know that for sure, because that's the way we calculate doses of carbo, right? Okay. All right. Also, when we talked about the checkpoint inhibitors, make sure you understand their mechanisms of action. So we're not going to do the IRAE stuff until later on, but I wanted to focus on kind of what some of their receptors are and their ligands are in that anti-neoplastic drug packet, right? Just because there's so many drugs, so I want to kind of focus more on the drugs that we've really spent more time with. Okay, so that's anti-PD-L1, anti-PD-1, CTLA-4 inhibitors. Let's see. What's next here? Make sure you know cell cycle phase specific versus non-specific drugs. Okay. Also, let's see. We talked about drugs that we use to enhance radiation therapy. So make sure you kind of are able to identify the terminology and a couple of the drugs that we typically combine. All right. And then on to nausea and vomiting, my favorite topic. All right. You can see I get excited about this because this is one of the ways, sometimes the only way I can make my patients feel better. All right, so make sure you understand some of the pathophysiology. We talked a lot about some of the different kinds of cells that produce neuropeptides. We talked about the neuropeptides themselves. Make sure you understand when to recognize anticipatory nausea and how we deal with it.
Is it only anticipatory, or should we know? Well, I mean, we should know all of them, but are you just saying only anticipatory?
For this particular question, you'll need to make sure you know anticipatory. I'll get to the other requirement in a minute. I'm trying to chunk these out into sections so you know what to focus on. But yeah. And then I'll tell you which ones I don't need you to know specifically. All right. I know that seems very nebulous. I'm sorry. You'll understand in a second. Okay. So anticipatory nausea, kind of how, you know, approaches to taking care of patients. And then we talked a lot about the treatment backbone needed for prophylaxis, right? We talked about the variety of different medications that we kind of stack together based on what the immunogenicity level of a regimen is. So I'd also like you to be able to understand what the salvage or adjuvant or adjunctive, sorry, I've got adjuvant endocrine therapy in my head. So salvage or adjunctive backbone for chemotherapy-induced nausea and vomiting. So what are some of the drugs that we use for salvage or adjunctive?
Benzos, cannabinoids,
Yep.
other antipsychotics.
Yeah. So there's a slide. Actually, I'm going to pull that, if I can pull that up, because I don't want to be too cryptic about this. I have it open. I do have it open. Okay, I'm going to share my screen. Try and share the right one. Okay, there we go. Okay, so now I have all of your faces covering this slide. Okay, here we go. Okay, so this slide, breakthrough treatment for chemo-induced nausea and vomiting, is a very important slide. Very important slide. Okay, so make sure you know what our options are. Preferred, what kinds of benzos we use, etc. And you notice we have corticosteroids here too. Okay?
Quick question here.
Sure.
So if they had given 5-HT3 antagonist and corticosteroid from the regimen from the guideline, we do not choose that at this point.
Well, it depends, right? It depends on what day we're at. Yeah, because if you have a long-acting drug, or if someone's already getting that drug, like dexamethasone, for example, you know, if they're having breakthrough on like day 2 or 3, then yeah, you're going to want to use something else.
Okay.
And I'm not going to make it so confusing. They're like, but you will have to select an appropriate treatment regimen for prophylaxis. And that means, you know, being able to recognize an immunogenicity level. Again, I'm only going to focus on a couple of the drugs that we've talked about. We've talked about cisplatin, we've talked about carboplatin, we've talked about doxorubicin, cyclophosphamide, etc. Like outside the scope of that, I'm not going to be asking you to tell me all the immunogenicity levels. But for a couple of them, it's important to know, especially if there's a dosing cutoff, like with carbo. So you'll need to be able to pick an appropriate regimen to start based on identifying the immunogenicity risk. And then you'll base there's one question that has like a couple of questions, or one case that has a couple of questions. And then from there, being able to identify what to do for a breakthrough based on the regimen that you selected. Yeah. Yeah. And
are you going to be giving AUCs if we need?
I want you to be able to calculate AUC and then figure it out, which is why the Calvert formula is important. What's that?
Back to the Calvert equation.
Yes. And it's a really important one. I promise you will get asked on your boards. It's just a really common question. And it's an easy thing for us to know, and you're going to totally impress your preceptors. You're like, I know the Calvert formula. So awesome. Okay. So we talked about that. Let's see. Next one. So far, everybody okay? Keeping up? Able to take notes? Do I need to go back on anything, or are we good? Okay. stop me if, you know, you need me to. Brand and generics are really important for this, especially because, you know, a lot of the nurses will only use brand names. And there are combination products that, you know, if you don't know the brand name, it's going to be really hard for you to decide if it's safe to give or not, given a context. All right. Doses for a couple of them. So the one that we really focused on was Zofran, right? Or ondansetron. That's a safety thing. So I do definitely need you to know what appropriate doses one can give, PO, IV, etc. Because that is also a board question frequently. All right. Let's see. I think that's. And then there will be a question on drug interaction that I kind of focused on. So a couple of the drug interactions we talked about were some of the NK1 receptor antagonists doubling the AUC of DEX, right? We also talked about at least one drug that we really shouldn't use in combination with one of the agents because of risk of QT prolongation. And hiccups are really common with NK1 receptor antagonists. So there's a pretty like prominently placed slide that I believe has like red letters. I try and make it obvious. So safety stuff is important for you to know. See, I told you I would be very specific. I'm being very specific. I'm trying to even point you to the exact slides to make this not like a hunting and pecking exercise for you.
Dr. Leva?
Yeah.
I have a question for highly emetogenic parenteral agents.
Mm-hmm.
For day 1, if we give olanzapine, ondansetron, 5-H NK1 receptor, and dexamethasone, on day 2, 3, and 4, do we continue 5-HT3 antagonist or no?
It depends on what agent you're using.
So if you use ondansetron, you continue on day 2, 3, and 4.
You can, but one of the things that I had mentioned before is that after 24 hours, they lose their efficacy.
Okay.
So, you know, it's one of the reasons why they've started pulling back on adding the 5-HT3 antagonists continuously. We used to have it, like for moderately emetogenic, they used to actually have it even through, like recommend through day 4. And we really don't anymore because we know that you're just increasing your risk of adverse events. So one of the things.
Which one do we use? Sorry. So which 5-HT3 do we use on 2, 3, and 4?
Well, it depends. Let me pull up the guidelines for you.
Yeah.
Have it actually.
Because I remember in one of the questions that you asked during irat, I think you continued 5-HT3 on day 2, 3, and 4. And that was not in the guideline.
Yes. And remember, I apologized for that because I said that unfortunately, when they changed the guidelines, that was an old question. So let me actually pull this up here for you. Let's see if I can. Okay. All right.
Yeah.
Can you see my slide?
Yes.
Okay. So if you notice, they've really pretty much removed the 5-HT3 antagonists from days 2, 3, and 4. And again, it's because we realized that we were just giving people more side effects. The one caveat, though, is if you give somebody the granisetron patch, then that's obviously going to continue to work, right?
Okay.
Days 2, 3, and 4. So it's there's some ambiguity there. And
okay, so you don't give it.
Yep. What this says to me is if the guidelines are encouraging or saying that you can give someone a patch that lasts essentially 7 days, then that's going to cover days 2, 3, and 4 for a 5-HT3 antagonist. So they're not saying you can't do it. They're just not showing that you can continue like Zofran or Dilisotran.
Palonosetron or anything. Okay.
Right. Well, palonosetron or Aloxi lasts for 3 days.
Yeah.
So that's why they don't carry it over. Yeah. So these guidelines used to be a lot messier. So what I can tell you is that in practice, people still pretty much, well, if they start Zofran on day 1, they'll pretty much continue Zofran days 2 through 4, even though, again, it's probably wasted medication. But I'm not going to.
For the exam, we don't need to.
No.
Okay. And what's option B? Can we change palanosatron to any other 5-HT3 antagonist or just palanosatron?
Yeah. So, what's really interesting about this particular option is that this option came out a few years ago, and it's only been studied with Aloxi. And they did this like really crappy they said it was a head-to-head, but it really wasn't, because the treatment arms were not equal. So they decided that like this combination was superior to use of Zofran. But, the fact is, even though, so the argument is twofold with Aloxi. Aloxi has a longer half-life, right? Which is why we only give it on day 1, because it lasts for about 3 days. Also, it binds to the 5-HT3C receptors with much more binding affinity than ondansetron. So the argument was, well, if it's binding with more affinity, then that must make it more effective. And the reality is, when they've been compared together, there's really only a slight difference in improvement of the Aloxi over the Zofran for delayed nausea. So you absolutely can. It's just that it was only studied like that.
Okay. Thank you.
Yeah, no problem. And I'm not going to get too much into the nitty gritty with this. I just want you to be able to recognize, like, oh, if it's a moderate emetogen, we do whatever we're going to do for 3 days, or some combination thereof. Or if it's a, highly emetogenic regimen, we're going to give them something probably through day 4, depending on what the options are. So I'm not going to get crazy and have you be like, oh my God, I have to like pick all these things. I just want you to like recognize also, what is the mechanism of action of the drug? It's hitting one target. How many targets am I hitting? How many do I need to hit based on the emetogenicity level? Okay. Yeah, no problem. And let me just stop sharing for a second. Okay. All right, so moving on to chemo-induced anemia. Before I move on, is everybody okay so far? I'll give you another minute to write notes or whatever else you need to do. Okay. All right, so chemo-induced anemia, we like chemo-induced anemia, don't we? Yes, it's pretty straightforward. Okay, so some of the things I want you to know. Mechanisms for blood loss in cancer patients. Why, or for anemia. Why do patients who are dealing with cancer and dealing with treatment, cancer-related treatments, why do they become anemic? And just a little bit of the pathophysiology in that. Kind of the major things is I want you to be able to tell me when it's appropriate to give someone a transfusion, or observe the patient, right? So we had some irat discussions on, when people are symptomatic, or if they aren't symptomatic, but they're at risk because they have comorbid conditions like heart disease, COPD, they're older, they're, maybe even if their hemoglobin isn't low enough to cause them symptoms, we worry that they could decompensate. I also want you to know when it's appropriate for us to give an ESA. And we talked a little bit about that. Does anyone want to tell me kind of generally what patient population we're giving ESAs to?
Typically patients in palliative care.
Exactly. What's the other kind of smaller percentage of patients who might get an ESA if they're anemic?
Who refuses to take blood product?
Exactly. It's a really important one. Okay. I also want you to be able to kind of understand just a little bit about anemia workup. So, just being able to identify a couple of the labs, especially for iron deficiency anemia, because that's something that you were exposed to before, when you did chronic kidney disease and probably iron deficiency anemia. So nothing crazy, just I want you to make sure that conceptually you understand what else we have to check when we look at a CBC with diff and when we do other labs. And then ESA dosing titration. So what I want you to know, remember in that box, I just want you to know when we're overshooting hemoglobin, what is the correct response? Whether it's EPO or DARBA, right? So we had one, it was like reduced by 25%, one by 40%. Okay. I also want you to know the time frame for like how long do we wait until we decide that this isn't working for a patient. So those are the things that are more important. You may have to calculate a dose and figure out percentages, or you may whatever. So just know that you may have to work backwards. So I want you to make sure that you remember. And for this, obviously, you'll need to know brand generic. Luckily, there aren't very many of them. So that should be easy. And then also make sure that you know what some of the transfusion complications can be too. So we talked a lot about like when to give transfusions and why we use ESAs to help reduce the risk of needing a transfusion for people who are palliative because it's disruptive. And we know that when we give a lot of transfusions, people can have iron overload, they can have fluid overload, they can have reactions. There's all kinds of stuff. So just want to make sure that you also understand why we do sometimes try to avoid transfusions unless we absolutely have to have them. We also have a major blood shortage in this country right now, especially with COVID-19. It's probably the most significant shortage we've had since 9/11 and Katrina. Okay. And then Dr. Fox has 3 febrile neutropenia. Oh yeah, there are a couple true false. Yes, I got a question. There's also 30 questions. I don't think there are any matching. It's too much of a pain in the ass for me to build that in ExamSoft. You will have multi-select, true or false, and mostly otherwise just, individual selection. Okay, so let me actually pull up Dr. Fox's exam questions too. Let's see. I did tell her I was going over the exam. I just forgot to mention that I would also talk about her questions. I'm sure she'll be fine with it. Okay. If I can find it. Yes. Okay, so need to be able to calculate ANC, obviously. Looks like you'll need to understand kind of what empiric antibiotic therapies for patients with different levels of risk based on the MASC score, or just kind of understanding what we would give for someone based on how sick they are. Let's see. How we treat someone outpatient or inpatient based on, again, that risk. That's it. Basically all the same stuff that we did on the application for her questions. And then for my 3 questions, I want you to be able to understand kind of the differences between neutropenia and febrile neutropenia, right? So we talked a lot about that in terms of looking at a regimen. If we don't really have that information available in the literature, going back and being able to determine, okay, well, let's see, what was the percentage of febrile neutropenia or neutropenia, et cetera, and which one do we act on when it comes to prophylaxis? And you guys understand that concept, right? Before I move on. Neutropenia is bad, but it doesn't necessarily mean that you have an infection. Febrile neutropenia means you might have an infection, and that's what we really worry about, because we worry that people are going to have complications. Rock on. And then determining risk, so know what the percentages are for, high risk versus intermediate versus low, because that will help drive your decision-making process for when to give somebody a prophylaxis. And then determining when it's appropriate to use a GCSF versus a GMCF. So when do we use a GMCF?
For treatment?
That's for treatment. for prophylaxis.
Right. So GM-CF we use for treatment. What kinds of things would make, what kind of circumstance would make us use a GM-CF for a patient?
Radiological or nuclear toxicity.
Mm-hmm. Yep. So that's one. What's the other?
Bone marrow transplant.
Yeah, we do use it for mobilization of cells for bone marrow transplant. But for a treatment perspective, when do we use them in someone who has febrile neutropenia?
Who did not receive CSF as a prophylaxis, and then when they are at the risk of getting into infection and getting it complicated, that's when we give.
Exactly.
Yeah,
exactly, because these drugs are not benign, right? So what are some of the potential side effects from giving either a GM-CF or a GCF?
Bone pain?
Yeah, bone pain. What's the really serious one? Well, there are a couple of really serious ones that we worry about.
Splenic rupture?
Splenic rupture, exactly. What's another one?
Respiratory distress.
Exactly. So acute respiratory distress syndrome. So obviously we want to use these drugs carefully, and specifically with GM-CF because it's allowing for expansion of more than just neutrophils. We know that there are some higher risk associated with GM-CF. So we want to be very careful and judicious about using them, or using it because it's the only one, which makes this easy.
I have a quick question.
Yeah.
If you suppose give us intermediate risk, like 10 to 20%, in that case, we'll have to make a clinical decision. Are we going to give prophylaxis CSF or GCSF or not? Are you going to strongly give us the risk factors that will trigger us to make a decision whether we're going to give it or not? I'm not too gray area.
Yes, absolutely.
Okay.
Yeah, I will call it out specifically.
Okay. Thank you.
Yeah, of course. Yeah, again, this is your opportunity to shine. This is not supposed to be a exercise in punishment. So my hope is that everybody does well and we can just get on with our lives and get on to the next exam. Cool. All right, so that's it. That's all 30 questions. So what I'm going to do for you is on Saturday, probably at about maybe 1 o'clock, I'm going to go ahead and open up the classroom, and I'm going to hang out here. If anyone has last minute questions or you're just freaking out and you need to talk to me, I'll be here. Or if you want to see my dog again. It's her birthday today, and she's literally never misbehaves. And today she was like, screw that, man. I'm going to get away with everything. She came in here, she stole the cat toy behind me when I was trying to talk to you guys, and she was running in between my legs and stuff. She never does that. So anyway. All right. So if everyone is okay, I'm going to go ahead and stop the recording, and then I'm going to allow you to get back to studying and preparing. I will email the password right at the time. Okay, so we'll have 30 questions, 1 hour. And if you have any problems, tech problems, please immediately notify Dr. Fox. Then if you have I know some of you use the comment boxes just to kind of think out loud and everything. So go ahead and, use those. But if you do have a particular question about a question, use the comment box, because I'm obviously not able to, answer questions during an exam, and I don't anyway. So this isn't different from the usual. There will be no go backs. So once you've committed to an answer, you're there. And that's important, because after you take this test, or the last test in this class, you are done really, truly taking high stakes exams until you get to your boards. So I want you to have as close to that kind of experience as possible to make you more comfortable with that experience. And you'll have a chance to practice next year when you do the RX prep and stuff. But, and I promise it's not scary. Everybody makes the boards out to be like, dun, 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 like the Darth Vader death march behind them when they talk about the boards. But, you know, they're really not that bad. Promise. All right. So I see a really funny side conversation happening here. Anyway, all right. No more questions? You guys good?
Dr. Can I ask you a quick question?
Yes, yes.
Would you suggest us to go back and look at the applications, or no, just focus on whatever you told us?
You know, I would say just focus on what I talked to you guys about. Because again, I'm trying to, like, as I explained before, I give you a funnel, right, of information. I give you a ton, and then we kind of narrow it down when we get to the exam. The stuff in the middle is really what we did with the app to help you understand some of the harder concepts so that when you go to the exam, it makes sense. So if you want to review them just for like decision making, reminding yourself of stuff, you can. But I would say for time purposes, you know, probably focus on what I specifically said. And I tried to target, you know, specific slides as much as I can, because I know there's a lot of material.
Okay, thank you.
Yeah, I love it. Yes, Karen, voting for Karen. Of course, I don't know who else is running, but awesome. I think you guys should. Yeah. Hi.
I know we don't have to know how to construct a TMN, but for this exam, do we still need to know how to interpret it?
You need to know how to interpret some of the information I give you. So I will talk to you about like where a primary tumor is, if there's a node involved, if there is potential metastasis or not. It should be very.
What I mean is, for example, in the irat, you could have give, you know, like
I did, yeah. But it's not going to be like that.
M2 and M3. So do we still have to not?
You have to understand the concept. But okay. I'm not going to put like T is this and N is this and M is that. Right. I promise you that question will be so crystal clear. You just need to be able to interpret the information I give you as a like pathology report.
Sure, thanks.
Sure. Okay. All right. Well, it's been real, guys. So I'll pop on again at 1. I have to upload to finish writing out all the questions or the answer choices rather. And then I'm going to upload it today. I will send you an email tomorrow when the exam is ready to download. And if you have any problems downloading the exam, anything like that, just let me know. Okay. And then for quiz link 8, I think I said this, I don't know if I said this to everyone. I will add some questions for quiz link 9 when I make it that will encompass some of the questions from today so that you can just have a reorientation to the information that I gave you. Okay.
Thank you, Dr. Leva. Have a good day.
Yeah, you too. Peace
Thank
out,
you.
guys.
Thank you. Bye-bye.
Yeah.